Hi everyone, and thank you for joining us. I'm Dr. Neil Gupta and I'm medical lead at Oviva. Alongside my role at Oviva, I'm an NHS GP, and I've also spent the last decade or so in senior leadership roles in NHS commissioning. So I think hopefully that puts me in a good position to talk about the escalating problems around NHS waiting lists. And in particular today, I'd like to talk about how providing better access to specialist weight management services can help us tackle those NHS waiting lists. So it's important to say at the start that waiting lists are not new. Prior to COVID, waiting lists were growing rapidly, and the government's core target that 92% of people had received their treatment within 18 weeks of referral had not been met for several years. And in fact, the NHS had not come close for some time. We all know what happened next. COVID arrived, and that meant that the capacity within the NHS to perform elective work like surgery was significantly reduced, whilst at the same time demand was being generated, and that's brought us to where we are now, where we find that over 7 million people are on NHS waiting lists for elective care. It's important to say two things about that 7 million figure. The first is that it's 7 million episodes of care and isn't necessarily 7 million individual people. So there will be people who are on multiple NHS waiting lists, and that includes many people living with obesity. The second thing to say is that only a small percentage of those people will be waiting for inpatient elective surgery. Others will be waiting for day case surgery, and the vast majority will have their care entirely delivered as an outpatient. Nonetheless, 7.4 million is a staggering number. So that is the bad news, and it is fairly bad. But what's the good news? Well, the good news is that by enabling better access to specialist weight management services, we can help tackle those backlogs for specialist care. But what is the connection between the two? So I think it's important to go back to the first principle of why we're trying to support people to lose weight in the first place. And it's not the weight lost per se or the change in people's appearance that is driving us. Obesity is a chronic medical condition that affects pretty much every system in the body. And the aim of helping people to lose weight is to improve their overall health by preventing the occurrence of weight-related health conditions and even trying to reverse or eliminate medical conditions related to obesity that have already become established. And in simple terms, the amount of benefit that you get in terms of your health and the number of conditions that you can prevent or reverse is proportional to the amount of weight that you lose. So for someone living with obesity, the greater the amount of weight that they lose as a percentage of their starting body weight, the greater the overall impact on their health. And what we know is that when people lose a modest amount of weight, and by that we mean around 5%, we start to see positive benefits in terms of their metabolic health. And that's things like improving people's blood pressure, but also improving their blood sugar. And that 5% target is really helpful when we're trying to prevent the onset of type 2 diabetes. If we want to reverse established type 2 diabetes, and if we want to reverse or eliminate other obesity-related medical conditions, we need to aim a bit higher. So we need to aim for that 10 to 15% range. And it's important to say that Tier 2 weight management services and even traditional Tier 3 weight management services will not consistently support people to lose that sort of weight in the 10 to 15% range. If we don't help people lose that sort of weight, then we can't help reverse those obesity-related conditions and we can't reduce the need for specialist care. And if we're being honest, up until now, the only means through which we could consistently help people achieve that kind of weight has been through bariatric surgery. Well, all of that is now changing with the advent of newer approaches within specialist weight management care. And that includes low-calorie total diet replacement approaches and, of course, the advent of newer medications such as the GLP-1 receptor agonists like Saxenda and the newer agent Wegovy. And what we're now seeing in our specialist weight management clinic is that we're consistently helping people to lose 10 to 15% of their starting body weight And in fact, we're seeing many people achieve even higher rates in the 15 to 25% range. In fact, one patient on our Saxenda pathway has lost a staggering 26% of their body weight. So how does all that relate to waiting lists? Well, the most obvious impact is that a significant number of people who go through our specialist weight management service will no longer need bariatric surgery. Bariatric surgery has had limited capacity in this country for some time, and with the advent of COVID, the rates of bariatric surgery dropped even further. So the waiting list for bariatric surgery are enormous, and people are often having to wait many years for that surgery. But the impact of that level of weight loss goes far beyond bariatric surgery. Over 25% of adults in this country are living with obesity, and the majority of them will have developed medical complications and conditions related to their obesity. And in many cases, that will have meant the need for specialist care and being placed on an NHS waiting list, or even several waiting lists. But what if we could help people lose a significant amount of their body weight, and by that I mean over 10%, by enabling greater access to these newer therapeutic approaches within specialist weight management care? As an example, a recent study from Australia by Jin et al. In 2021 looked at total knee replacement and showed that weight loss of over 7.5% was associated with a reduction in the need for total knee replacement of 31%. Interestingly, slightly lower weight loss of 5% did not have the same benefit. Well, what we're seeing in our specialist weight management clinics is that we can consistently achieve that sort of weight loss of 7.5%, which is really important if we think about a high volume specialty like orthopedics, which often has very large waiting lists. But more importantly than the waiting list, the reason people no longer need the total knee replacement is because their pain that they're experiencing on a daily basis has significantly improved. So this is a win for patients and it's a win for the system. So imagine what we could do for patients if we could enable greater access to these newer weight management therapies, and what impact we could have on waiting lists for specialist secondary care, but also waiting lists for primary care if we can make these newer therapeutic approaches available to far more people living with obesity.
Brilliant. Thank you so much, Neil. I'm Lucy Diamond. I'm the Clinical Director for Innovation here at Oviva, and my background is a diabetes specialist dietitian with almost a decade of care in the NHS prior to coming over to Oviva. I have the pleasure today of asking you the questions of the talk around NHS waiting lists and weight management services. So we've had a few questions sent in prior to today, and it'd be great to get your thoughts if that's okay, Neil.
Sounds good.
So first one sent in, why must reducing waiting lists be a priority for hospitals and the wider health system? I love this question, particularly because there's so many conflicting priorities.
Yeah, thanks, Lucy. And I'm sure most of this is well known to people. But firstly, just to consider that number, 7.4 million. I mean, that is staggering. And at best, that is an inconvenience for some people. But for a lot of people, they're living with daily pain and disability, and it's having a significant day-to-day impact on their quality of life. And I think there's been a lot of headlines recently about the economic impact of people not returning to the workforce because of ill health, and there's no doubt that those waiting lists are contributing to people being unable to return to the workforce, and that's having an impact on the economy of the country. Actually, when people survey this, so there's the British Social Attitudes Survey, the number one reason for dissatisfaction with the NHS amongst the public is long wait for a GP or hospital appointment. And I think that brings us on to the final point, is the knock-on impact of people waiting a long time to get specialist care, is that they're often visiting their GP multiple times, often in significant distress. There's often very little you can do for people. And so it's not a great situation for primary care or for patients, and it's having a knock-on impact on primary care capacity and primary care morale.
Just taking that question a bit further then, thinking about with your commissioner hat on, what's your experience of getting weight management services commissioned?
Yeah, I think it's not great, I think is the summary. And I think, the first thing that I think everyone would accept is that access to specialist weight management services is generally very poor, and it's certainly very variable. So it is the classic postcode lottery. And I think from my experience as a commissioner, I think it's on a par with fertility services in terms of the variation in commissioned services. There's a lot of reasons for that, but I think sadly one of the reasons is that specialist weight management care has simply not been a priority for the NHS. And again, there are multiple reasons for that, and some of those come down to attitudes and perceptions. So certainly amongst some people, obesity is not seen as a medical condition, and that include many doctors in that. Some people see it as a public health problem, and sadly some people still see it as a personal issue and a personal failing. And those sorts of attitudes are improving, but they're sadly still there amongst senior decision makers. And I don't say any of that to be pessimistic, actually. I think it's important to be realistic about what's been happening. But what we've seen over the last couple of years with the advent of these newer therapeutic approaches, such as the GLP-1s and total diet replacement, low-calorie diets, is that people are finally starting to look at what specialist weight management provision they have in their area. The difficulty is they're doing it at a time when the financial picture in the NHS has never been bleaker. So it's really difficult to find that extra investment for specialist weight management care, even though we know that it's good for patients and potentially even life-changing for a lot of patients. But really, there is a need to convince senior decision makers that this is where they should be putting their money. And I think that the only way you're going to do that is if you link it to the key strategic and political priorities nationally or at the ICS level. And the number one political priority is waiting lists. And that will be the case for some time. The second biggest political priority is the money. And, it's important when building the case for a new specialist weight management care to show how Tier 3 or specialist weight management care can result in a return on investment, but maybe that's for a different webinar.
Absolutely. I think you made a really powerful comment earlier. This isn't talking about weight loss from an appearance perspective. This is health. This is about looking at preventing complications of living with obesity.
I think that's right. And, especially going back to some of the attitudes that are there and some of the weight stigma that sadly still exists, it's important that we bring this back to the medical implications of obesity and the medical benefits of treating obesity. So we talked a bit about the metabolic benefits of that modest weight loss at 5%, and then as we get higher weight loss at around 10%, we start to see benefits on other systems in the body. So we talked about orthopedic procedures and the impact of knee arthritis. As we get into that 10 to 15%, we start to see benefits on other systems. In thinking about gastroenterology, we start to see improvement in things like non-alcoholic fatty liver disease, and especially the more advanced, more inflammatory stages of non-alcoholic fatty liver disease. There is an epidemic of non-alcoholic fatty liver disease mirroring the obesity epidemic, and that is producing a significant impact on gastroenterology services, which often have large weights. Thinking about gastro, again, 10 to 15% weight loss will have a significant impact on conditions like gastroesophageal reflux. So there are multiple benefits just thinking about one specialty. Another high volume specialty, often with high waiting lists, is ear, nose and throat. And as you go above the 10 to 15% weight loss achieved, then you start to get benefits more from the mechanical impacts of obesity. So we talked about knee arthritis, but actually that level of weight loss can have an impact on things like obstructive sleep apnea. And again, lots of people are currently on waiting lists awaiting assessment or treatment for conditions like sleep apnea.
And in the final few moments, the question for me is talking about long term. So two angles, I suppose. One is the longer term weight management piece. I suppose there has been some fear around when someone comes off a GLP-1, what happens then? Does the weight come back on? And similarly with the TDR, so the low calorie approach, how do we support people to maintain that weight loss so they don't come back onto the waiting list?
Yeah, thanks, Liz. I think that's a really great question, because it might sound like we're just pushing the medication or the total diet replacement approaches, but that's absolutely not what we're about. I think the important thing is to think about what you're doing to support people alongside those newer therapeutic approaches. And absolutely, for every single person, there needs to be a package of behaviour change support. Because what is going to happen, I think it's pretty obvious, if we don't do that at the end of 2 years when people are no longer eligible for those GLP-1 medicines, the weight is going to come straight back on. So it's really important that we help people understand their relationship with food, with activity, and we use that window of 2 years for a GLP-1 in particular to help them establish a new relationship with food and new habits and behaviours. Otherwise, predictably, we're going to see the weight come back on, we're going to see those medical conditions come back, and it will have the knock-on impact on waiting lists.
And final thought from me, which is maybe for another day, for another webinar, is thinking about longer term vision with the NHS. So rather than thinking about the current waiting lists and how we get people off of those waiting lists, should we be pushing towards prevention of the complications associated with obesity?
Yeah, I think that, absolutely. If we were to do this in the optimal way, we wouldn't be waiting for people to develop these conditions. We'd be intervening far earlier when people are overweight or in the early stages of obesity, rather than waiting for people to have a BMI over 40 and to develop these established complications. I think there's a lot more that we could be doing in primary care. I think there's still a lot more training that's needed around how to have conversations about obesity, how to assess people for the medical complications of obesity, so we really understand someone's risk profile, and we're really trying to intervene as early as possible and not let things get to the stage where people have established diabetes or non-alcoholic fatty liver disease or sleep apnea. But we're being completely honest, we're probably a long way away at this point.
Amazing. Thank you very much, Neil. Thank you.
Thanks, Lucy.